Come on, give me back the screen. Okay, Carla and Barbara, take it away. We'll move to the other end of the age spectrum here.
Okay, so we do have a PowerPoint as well.
Do you have that?
Well, we could probably do that. Let's see what we got.
So I'm going to just start reading our objectives while Van's finding our PowerPoint. We have a little girl that's come into the clinic. She's 4 years old. Oh, wait, let me back up. I'm sorry. Wrong slide. Objectives. Ding. Thank you, Van. We're going to discuss the case study, of course. We want to show you the prevalence and incidence of Down syndrome, including special risk, the long-term effects of Down syndrome, the genetic basis, including patterns of inheritance and other factors that influence the genetic expression, and discuss key issues in primary care and health maintenance for children with Down syndrome, and then learn about some resources for providers and families. And
PowerPoint we don't have, so we'll just promote this.
Oh, that's strange. Okay, so we'll just move forward. Sorry about that, guys.
No worries.
So we have a little female that's 4 years old, and she grew up in, it was in the Midwest, somewhere in Ohio. And so her family got relocated, and they're now here in Albuquerque. So they've come into the clinic. They need to get established with a primary care provider. So for initial, most of the time with Down syndrome, they are known of in utero and or diagnosed at birth. That's most common time. So we wouldn't necessarily be looking to diagnose somebody at 4 years old who came into the clinic. However, it could happen. But she comes in with an appointment just to kind of establish care, and mom brings her in. And we didn't have the luxury of having her records available at the clinic when she came in, because the mom said that the other clinic was supposed to send them, and we didn't receive them. I'm sure that's never happened to anybody else. So our today is trying to hurry up and get everything sent. Mom knows that she saw a cardiologist there. She had some other specialists that were working with some of her delays.
Yeah. But generally, she's a stable 4-year-old right now. You can see on the screen up there, 4 years old, female, BMI of 17. She's white. She's only taking a children's multivitamin right now. The only thing that the mother has concerns for is she thinks that she's having a little bit of difficulty seeing. Blood pressure, vitals were fine. Physical findings, you guys can read them up there to save a little bit of time here, but we don't have any lab work on her or anything. The MA did perform a vision screening with the Snellen picture chart, and she did fail that. So she just wants to establish care after a recent move, and we don't have the medical records, her past medical records, as Barbara mentioned.
Okay. So unfortunately, the next slide that we had is a graphic that shows all the long-term effects. And we'll get this posted for you guys. And this is from the AAP 2011 clinical report, and it's the health supervision for children with Down syndrome. And so it kind of lists, there must be at least 15 items here that are all real problems for children with Down syndromes, or potential problems, based into 2 percentages. So the highest percentages of deficit for Down syndrome children are hearing problems at 75%, and these are the long-term effects. Vision problems of 60%, or excuse me, 80%. Obstructive sleep apnea is 50 to 75%. Otitis media is 50 to 70%. Congenital heart disease is 40 to 50%. And there are a number of other things involving their eyes, like cataracts. There's also GI, thyroid, seizure issues, blood deficiencies, leukemias, celiac disease, autism is always a possibility. And so when you guys see the slides, you guys will be able to appreciate that. But we wanted to share with you because these kids they come with a long list of potentials, and not every Down syndrome has everything maybe fully expressed. Different kids have a different degree of deficit with those.
So we had another slide about prevalence, incidence, and special risks. So in our Lane textbook, it says that we do know that there is between a 1 in 700 and 1 in 1,000 incidence in mothers under the age of 30 years old. And that can increase up to 3 times in advanced maternal age. So we can think of it as by the age of 45 years old, there's a risk in 1 in 40. So going from 1 in 700 or 1 in 1,000 to 1 in 140 with possibility of Downs, that's pretty significant. The NIH says that 1 in 691 live births in the U.S. do have Downs. It's the most frequent chromosomal cause of intellectual disability, and it occurs in all ethnic and SES backgrounds. If one or both parents have a chromosomal disorder, there's obviously going to be a little bit higher chance of having a child with Down. So if one or both of the parents have the disorder.
And that's any chromosomal alteration.
Yeah, it
not
doesn't
just Downs.
Yeah. So either one of the parents, any type of chromosomal disorder. It was hard to find specific risks related to each ethnicity. It does affect all races and ethnicities. I feel like the research that we found is more frequently within older white females, just because they tend to be.
Well, the other interesting thing is there's a number that are detected due to blood work at about 20 weeks. So the number that are detected and the number that are born is almost half. And so the research we found said, well, was part of their question was, is it that this population, like the Midwest, for example, has a high number? Do they really have more Down syndrome children, or is it that they carry those children to term? And so there's some cultural, there's some maybe religious reasons, there's some different factors that play in there. So they said that they really don't feel that they have a good handle on what group may actually be the highest incidence because of the high rate of abortions because of abnormalities.
And then the long-term effects that Barb did talk about, I want to reiterate a really great resource, the American Academy of Pediatrics, the clinical report for health supervision for children with Down syndrome. It is a really amazing article, and it really helps guide us through as practitioners of what to do. We had a slide on just the karyotype. As you guys probably are aware of, it's a trisomy of chromosome 21. So there's just 3 chromosomes for 21.
And then there's a little picture on the slide that just kind of shows the different areas that we've already talked about that can be affected. So in the interest of time, we'll move forward here.
Sure. So again, going back to that AAP clinical guidelines, we picked out what we thought were the most important things that relates to primary care and health maintenance. So it's the same immunization schedule as a child without Downs. It's important to measure TSH, CBC with diff, hemoglobin A1C annually. Discuss signs and symptoms of celiac, OSA, obesity, overweight. So sleep studies would be a good idea to keep in the back of your mind for these patients. And again, this is all going back to that list of what Barb was talking about earlier. Monitor neurologic dysfunction, including seizures. IEPs through public education is a great resource. Referrals for ophthalmologists, cardiologists, or audiologists. Also spinal x-rays if symptomatic for let me see if I can say this, atlantaxial subluxation. And then, of course, autism and ADHD screenings. There is also a Down syndrome growth chart that is also really helpful, because if you plot a Down syndrome child on a normal TBC or hoop, they're not going to have a really nice curve on there. So it's most EMRs do have a little check mark that you can hit. This is a Down syndrome child, and it'll give us an appropriate growth curve that we can follow. But basically, this slide is just about being aware of health screenings and extra health maintenance that might be appropriate. And
being very aware of all those things.
Yeah.
And then the last two slides are a brochure that we had made for patient and families, and it's a front and back handout. So on one side, it just kind of states what the risks are, like Carly said, about increased maternal age, so there are screenings that they would need, some issues with stomach, autism, severity of their disease, such as that. The other thing is to kind of to encourage parents is that there are some Down syndrome kids who have lived to be 60 years old, and even beyond, and they don't necessarily have the average lifespan isn't as long as so-called normal children. But with modern medicine and all the screenings and everything that they're living to be older, as well as much more productive out in the communities, going to school, doing all the things that they would need to do. And they're just the most adorable, happy little children. I mean, which is really super nice. And then the other side of the handout is resources. So those include some of the national things, and then there's some local resources and resources for providers. So we'll get that loaded up on the system so everybody will have it.
But there are great resources here in Albuquerque as well. The great thing about a lot of the websites, they're also in Spanish too.
Yeah, that's really nice. Questions from anybody?
Very good. Any questions about anything at all? I will add that I've noticed a lot more adult Downs in my lifetime and involvement both even prior to being in medicine. Was not unusual for Downs to not live past 20 or 30 years old. And now we've got people who are retired, 60 some odd years old perhaps, and do well. So there may be more expanding database, so to speak, growing with how do we manage adult Downs and particular things. Of course. Any other thoughts or questions from out in the field here? We'll give you a moment to figure out where the unmute button is on your computer.
And it's really nice we were able to talk to some moms that do have children with Down, and it'd probably be a good idea to hopefully get a longer appointment time for these patients.
Oh, no doubt. That would easily be a good 30-minute appointment there. Yeah. In a clinic that might typically give you 15. So let's just put it that way. An hour might be better. All right. Well, I think we'll just call it quits then at that particular point. We want to thank you very much for not only one, but two case presentations today. We're still working on trying to get this format smoothed out for the pediatric end of things. I already have a couple of thoughts about this, and we'll talk a little bit more with the hub team, and Tamara and I will too, about how to fine-tune this a little bit. But I think having access to the resources for participants, particularly those who are not students and might be active clinicians, would be a nice thing to do. And if we figure out that little detail in there, I think we'll have it fine-tuned. Very good, by the way. First time through, it's always scary to be the first ones to pull that off, so thank you very much for doing that. As always, for all our guests that are out there in the virtual end of things, thank you for taking your time today. We do have extended hours now for our clinic. Keep in mind, next week we'll have Christine Zambak, who is a DPT, who will be here to show us some things about how to assess a knee. Which will be pretty neat, and we'll have an exam table in here so that she can do that for us. Actually, it's a massage table, but we're not being particular. So if there's nothing else to be said, please, by all means, be sure that you get your evaluation done here. Be sure that you do not click student and you click clinician, and go ahead and enter all that information in there. You can use the CME if you'd like to use that, but that will not only give you a certificate to show proof you were here, but will also allow you to complete our survey as well. So great. We do have student presentations next week for both case presentation and a case study. So we'll kind of continue our special 6-week program here on pediatric genetic disorders. So thank you very much for this. And as always, appreciate your time. And until next week, we'll see you next time. Practice well, my friends. Do not click student. Just go click clinician and go from there. Okay, Renee? See you guys.
Thank you.
All righty.
Bye.